Okay, good morning, everyone. Welcome to the session with Meet the Expert on advancing sedation strategies. My name is Yahya Shehabi. I'm an intensive care specialist and a trialist at Monash University and University of New South Wales in Australia. My colleague and friend, Michael Reade, is a professor of intensive care at the Brisbane Royal Women's Hospital and Queensland University. We will both run the session, so I'll start with a brief introduction about the session and what we plan to do. So, sedation and analgesia, as some of the speakers said yesterday, is not really that sexy in intensive care because it's not a ventilator, it's not an inotrope, it's not a vasopressor, it's not a dialysis machine. But I, myself, and Professor Reade today will convince you that it is as important as those in terms of interventions. Now, while it's not sexy, unfortunately, it is pretty emotive, and people feel pretty emotionally attached to their sedative syringes and the patient, how the patient is, and not just attached, but they also make their own judgment of what's good to the patient. And when they make that judgment is made like at the time, you know, it's 9 p.m., the patient gotta go to sleep, I gotta wind the propofol up, make them sleep. At 6 a.m., I'll stop it, they can wake up. I think this is good for them. And many people have a lot of sort of beliefs like that. So in today's session, we're hoping to present to you evidence and convince you that the way sedation should be managed is really part of a strategy of patient management to improve patient outcome, not just at the minute you're looking at the patient, but also in terms of short-term outcomes, intermediate-term outcomes, and longer-term patient-centered outcomes. So what we're going to do today is we're going to start by like a question and answer session. Michael will be asking questions, and there'll be opportunities for you also to ask questions and comment on answer that's been taken, and we'll see how we go. Michael.
Thanks, Yahya. So that's a great introduction. And as suggested, we're going to have some questions. So I'm going to ask Yahya some questions. We're going to, as best as possible, ask you guys some questions as well. We'll try and make this a little bit interactive. And then towards the end, we're going to present some cases. We're going to see how Yahya will manage those challenging cases in sedation and some delirium management as well. And then hopefully open that up to the floor as well, see how you might manage those cases, and maybe that'll stimulate a bit of discussion. So a really kind of broad question to start with, Professor Shehabi. So if you were to characterise your general approach to sedation, how is that different now compared to what it might have been 10 or 15 years ago?
I think 10, 15 years ago, we were faced with multiple trials. Those multiple trials essentially focused on short-term outcomes for those patients. Those trials were characterized by mostly being single center, mostly being trials that had a small numbers relatively, and most of the trials have shown basically some significant benefit in the intervention proposed. Although those trials are 20 years age now, but those trials have impacted our thinking, also impacted our practice. Now, 20 years ago, we had also medications that today we have medication we didn't have 20 years ago. So 20 years ago, we were pretty much standard on benzodiazepines. Propofol was finding its spot in intensive care. Dexmedetomidine was just starting to put its head up. And most of the sedation was really that type of sedation where benzodiazepines is the mainstay. There was still a lot of use of relaxants in many intensive care units, and there was basically no monitoring of what we do, whether in terms of sedation level or delirium, emerging delirium of those patients, or the impact of any of those on these on patient outcomes. Over the following 10 years, multi-center trials have been conducted and essentially showed that in the context of modern sedation in intensive care, those interventions that was primarily single-centered did not stand up to the test of multi-center trials. Also did not stand up to the test when more modern techniques of sedation is being used. For example, the use of sedation assessment has become more common. Assessment of delirium became more common. Our awareness of the depth of sedation relationship to worse outcomes, long-term worse outcomes, such as mortality, became a bit more prevalent. So we moved from those days and 20 years ago, we moved today to a practice where it's pretty much outcome-based practice. So today we're targeting sedation level continuously, almost every hour or 2 hours. We're measuring delirium level in patients at least every day. We're using more a combination of sedative agents rather than relying on a benzodiazepine that gives you intense sedation. We're now relying more on kind of like driving a car, where you have a drug for cruise control, and you have a drug for fine-tune, accelerate, decelerate. So the drug that we could use for cruise control, for example, will be a drug like a background of dexmedetomidine, which will give you delirium prevention, reduction, and a lot of other agents you're giving, and also using a drug like propofol for fine-tuning, where you want to accelerate or decelerate, while your speed limit that you observe on the road is pretty much your RAS target that you look at the patient to say, well, today I want the patient to be a RAS of -3 or -2, but from this evening when I review a patient, I want him to be at 0 or -1. So we've become a bit more targeted in our sedation practice, and we have become a lot more outcome focused, not short-term focused, but outcome focused in terms of intermediate outcomes and long-term outcomes. So that's pretty big leap over 20 years in our understanding of sedation. And it's all due to the early trials that have been done despite the limitations, plus a lot of the trials that have been done over the last 20 years, which we have learned a lot from.
So that's an interesting insight, probably one that many people in the room, and certainly I wouldn't necessarily put as my first line practice, to have 2 sedatives and to be titrating one while another sits in the background. Just open the question to the room. Not sure how this is going to work. It's a big room, lots of people. We've not done this before, and unfortunately there's only 2 microphones, so I'm going to have to repeat what you tell us. But ask the same question of the room. Are people in the room doing something differently now to what they're doing 10 years ago? And specifically, is anyone else doing what you've just heard, having one medication running at a constant level and another titrated up and down? Anyone like to take that on? I don't know how this is going to work. No? All right, well, we'll come back. We've got some other questions for you, so we'll see how we go. All right. So one other thing that we talked about yesterday as we were thinking this through, was we probably many of us are in similar situations where we come on in the morning and we see management that's been instituted for what seems to be good reasons overnight, but with which maybe with a view to the longer term outcomes we disagree. So can you give us some examples of that sort of common management that's been instituted overnight that you might say you commonly have to correct that the residents or registrars have instituted overnight?
Yeah, well, I don't know about your ICU, but in my ICU, everything bad happens at night. And you come in the morning and you dread the morning handover because you're going to just hear the stories one after the other. And then you ask why, nobody can tell you why. And sedation is not an isolation, it's just exactly the same. But sedation seemed to be a bit more problematic because it's people believes at night time that dictate what happens. And it's pretty common that you come in the morning and you leave in the evening with the evening round and say, let's try and keep this patient awake. And you come the following morning and the patient being put to rest -5 for the most of the night. And then the person who did that already gone home. So you can't ask them why, you can't educate them that this is not the right way to do it. But inherently, when you ask specifically the nursing staff, most of them believe that giving people a higher infusion of propofol or midazolam or whatever is running to put them to sleep is a good thing. Now, what they don't really recognize is that that is actually anesthesia, is not sleep. So, anesthesia does not equate to sleep. Anesthesia does not rejuvenate your body. That's why when we're tired, we don't go to the next clinic and say, put me asleep for a day. I want to rejuvenate my body. Sleep is a different, it's a physiological thing. While what we do to our patients at night time with sedatives like propofol or benzos and others is a pathological thing. So we're actually, give detriment to those patients. So we're trying to avoid that by using, other sleep promotion, promotive interventions. And Marker will be talking about the use of sleep in intensive care, including the use of dexmedetomidine or melatonin or other agents that would enhance natural sleep. And some people have used non-pharmacologic therapy, such as, earplugs or headphones or music or distraction, or keep the patient awake in the daytime. So you just kind of like enforce their day-night time, orientation. That's usually helpful. That's the one thing that really annoys me when I go in the morning. I find that patient being really put asleep for a whole night. It takes half the day to bring them back to where they were when we left the day before.
Yeah, I definitely agree with you. It's a common misconception that sleep equates to sedation. And I suppose there's lots of evidence for non-pharmacological things on the ward. There's probably less robust evidence for things along those lines in the intensive care unit. And as you say, I've got to talk on this in a couple of days' time. But probably the most important thing is just to stop waking the patients up at night. And there's lots of studies that show that it is possible to reduce the number of nursing interventions that are performed between midnight and 5 a.m. and that when you do that and then you objectively or even subjectively measure the patient's sleep, in other words, you ask them if they're able to reply, did you sleep better when we didn't wake you up? Not surprisingly, they say, yes, please continue not to wake me up in the middle of the night. It's a very simple intervention. Excellent point. If I was to ask you, we've spoken in generalities up until now about sedation as if all patients are the same, but of course they're not. Do you find some patients particularly challenging to apply a sedative regimen for?
Yeah, I mean, definitely and I'm sure you've all seen those patients, young patient, pretty solid, probably recreational drug user or IV drug user, come in with aggressive behavior, he's hitting everyone, go and have an operation, come back tubed, and then, you're kind of like, what am I going to do? Am I going to keep them flat until God say they're ready? Or am I going to have a fight with them and just see what happens. And that's pretty much is really a clinical dilemma at the bedside. And the nurses have absolutely, and correctly so, zero tolerance to anything that would, encourage or promote an aggressive, uncontrolled behavior. That's why those patients I found actually the hardest patient to sedate. And that's where what I call not multimodal, but what I call multi-purpose sedation would be the way to go with those patients. So those patients I usually rely on heavy use of antipsychotics and also heavy use of multi-purpose sedation, such as a combination, as I suggested before, Michael, dexmedetomidine and propofol plus an antipsychotic on board. And I'm pretty generous with giving antipsychotics. I mean, my colleagues, when I go to one of those patients and I put them on 200 milligrams of quetiapine every 6 hours, I see the eyebrows, what on earth are you doing? But as the patient, is heavily loaded with an antipsychotic, so like quetiapine, it becomes a lot easier to fine-tune that cruise control and get them out of coma towards extubation. Sometimes you just have to bite the bullet, and when they're opening eyes and breathing on their own and they're ready to go, just get the tube out and then manage them at the bedside. The one thing that I find very comforting for patients, for nurses, is to see a senior person at the bedside managing that patient. And I know that when they see a consultant next to the registrar at the bedside managing that difficult patient, they feel fine. They feel comfortable that something will be done, whatever it is needed, to keep things safe. And that's pretty important to do. The other group of patients, which I'll be talking about tomorrow in the clinical challenges session, are those patients who are hemodynamically unstable. And there is a tendency to use benzodiazepines in those patients, thinking that benzodiazepines may offer a better, cardiovascular stability. So we'll have a discussion about that tomorrow at the clinical challenges. I don't want to steal my own thunder by doing that today, but if you're interested to see how those patients are managed, please come to the clinical challenges session tomorrow.
So all great comments. I think they are the two very problematic problem sets in sedating people. We similarly have I suppose you could say, a tradition in Brisbane of using benzodiazepines in hemodynamically unstable patients, and I tend to try and buck that challenge, and I'm very pleased to often find that propofol or even dexmedetomidine in small doses is really quite safe and doesn't cause any hemodynamic instability, which I expect is probably what you're going to point out tomorrow. So I open again the floor to comments, and maybe ask you if you've got any challenges or particularly difficult patients, or indeed any comments on what's just been said. So I'll bring the microphone over. How's that?
Yeah, I think we'll swap.
Great, thank you very much. Zuhair Al-Asiri from Riyadh, Saudi Arabia. I have two questions. What about the strategy of live sedations and early, waking trial every single day in the morning? You try to, live sedation, see if the patient is arousable or no, and that might help as well to decrease the need of sedations. That's number one. The second question is, do you have any experience of inhalation sedations using in ICU?
Yeah, in terms of the first question about daily wake-ups, I think in modern sedation practice, if you're practicing good sedation practice, you should not need daily wake-ups. I think daily wake-ups is for bad sedation practice. If you're used to have your patient in the morning completely zombed, then yes, you need a sedation holiday. But if you practice sedation where your sedation is targeted to a RAS level, then you should not need to have daily wake-ups on those patients. So daily wake-ups is part of a sedation strategy, but that's if things are bad. If you've got someone who's in a prone position and paralyzed for 2-3 days, and then you're about to start winning things back, yes, you may start giving them sedation holiday, but that's part of your weaning process, not part of a systematized daily thing I would do in my ICU. And I think the trials by the Canadians has been pretty clear that if you're using daily wake-ups with, if you're using a nurse-driven or a light sedation-driven protocol, there's really no benefit. In fact, there may be harm in the wake-ups that you do. In terms of inhalational agents, I think they're coming on the scene now. They're now at the stage where I would say dexmedetomidine was 15 years ago, where there was multiple phase 2 and phase 3 trials that showing that it does the job as a short-term outcomes. For short-term outcomes, it does the job because it's a sedative, it's supposed to provide sedation, and it can be weaned. We know how to do that. They do it in theater. There's no reason why we can't do it in ICU. However, remains the question is that we need to look at the other things that we would not normally see in what I would call relatively small size phase 3 trials, unintended consequences of an intervention, long-term outcomes of such interventions. They're the ones that would determine where inhalational sedation would stick as part of the armamentarium of sedation in intensive care.
Yeah, indeed, excellent question. So is anyone currently using inhaled sedation in the ICU? Yeah, at the back there, yeah. Whereabouts do you work? Sweden. In Sweden, yeah, okay. Yeah. All right, so one, there you are. All right, any other particularly challenging questions? No? Yeah. Yeah. So I'll repeat the question. It was around your approach to analgesia, which we know goes hand in hand with sedation for many patients, especially for surgical patients, but not just for surgical patients. In fact, my pet hate when I come on in the morning, so I answer my question to the AR, is to find a patient on just a sedative and no opioid or no analgesia at all. I always tell the residents off for that, even if they're not a surgical patient. So the question is, what is your general approach to analgesia?
I think that's a brilliant question. I'm very pleased you brought it up, because analgesia must be the cornerstone of managing patients' sedation and analgesia in general. Use Jusidis analgesia, so the patient is absolutely have adequate pain relief. That's pretty imperative. Well, that's what the principle of analgesia first. So that's pretty important, because once you give people adequate pain relief, you take away a lot of their agitation, a lot of their anxiety, a lot of their distress, and the need for sedation becomes a lot less in terms of a quantum and duration. So analgesia first is pretty important. My approach to analgesia is pretty simple. We usually start with fentanyl, and if the patient is able to use a patient-controlled analgesia, that's well and good. If they aren't able to use it, we usually use a kind of like a low-dose fentanyl infusion. I usually circulate opioids every 3-4 days just to reduce the tolerance of a single agent. So I'll go from fentanyl, go to hydromorphone, go to morphine, oxycodone, come back to fentanyl. I would not stay with one single agent for a week, for example. You know, my practice is about day 3, day 4, I will change the sedative, the analgesic agent. But that's pretty important. Also, what's important is that patient perception of pain is different. So you must, when you give pain relief, you must be targeted to a pain score. So if the patient is able to report pain, we would encourage you to use the visual analog score. And if not, then you use the CPOT as a critical care pain observation pathway for that. Yeah.
Yeah, please. Both excellent questions.
Okay.
So ketamine
Yeah.
and delirium.
Yeah. Ketamine in low doses is used a lot as an analgesic dose. So it's a sub-anesthetic doses. When I'm talking about low dose, I'm talking about 8 milligrams an hour or maximum 10 milligrams. Once you go above that, then you start buying all the bad smell. You get the agitation, you get the dysphoria, you get the delirium, you got all that stuff. So if you're going to use ketamine, use it as a low dose and in combination with an opioid. The use of ketamine on its own, I don't really encourage. If you're going to use it in a combination with an opioid, and both works very well, especially on those very difficult, patient post-operative, big incision, big this, big that, solid gas. That's what I use. In terms of approach to delirium, first is look at what the triggers are. That's very important. I know people talk about non-pharmacologic intervention, which I think, unfortunately, despite all the hype, they are not able to be delivered systematically and consistently to all patients. So you will always end up relying on a pharmacologic intervention. I would look at it in terms of if the patient has a hyperactive delirium or a hypoactive delirium. If they have a hyperactive delirium, then I would usually use a combination of dexmedetomidine and quetiapine. I start with a low dose of quetiapine, and I start with a mid-range dose of dexmedetomidine, about 0.5 to 0.7, until the patient, delirium resolve. If the patient is hypoactive delirium, then there is no point in actually giving them pharmacologic agents that will make them more hypoactive. So they're the patients that there should be a focused, non-pharmacologic approach to it in terms of family orientation, day-night orientation, review all the drugs they do, make sure they have a good night's sleep, get them out of bed, get them out to the balcony, get them to the coffee shop, all the things that you would do to make yourself feel better. They're the things that make those people feel better.
So I'm intrigued by the question about ketamine. I'm curious to know if anybody uses it as a primary sedative. Yeah. So the reason I ask is I just got back from Papua New Guinea, where I suppose a low-income country, they don't have access to many of the things that we all take for granted. And in some of the hospitals in PNG, they were telling me that they use it as a primary sedative. They don't have anything else.
I think in low middle-income countries, I'm from South Africa, and certain parts of the country in South Africa use ketamine as a main sedative. We don't have dexmedetomidine is at your tertiary and slightly more resource centres. But if you're in a district or regional hospital and it's slightly less, we don't have dex. Propofol, the problem with them is if you use them together, we then have to consider the actual cardiac monitoring quite significantly, which can be a problem with poor nursing staff. So we end up using ketamine because of its slightly more hemodynamic, so it was interesting to hear that small doses of it. And then I was going to ask then, in sedation, is it a no completely? Where we end up actually using it as a sedation agent.
I'm so pleased to hear you say that, because I think when we write our guidelines, we tend to write them just imagining that everyone works in a hospital that has, almost no restriction on resources that we can apply. But the people who read those guidelines and look to them for advice are often not in those perspectives. And when they read, they're perfectly competent doctors as we are, when they read that this must not be done, sometimes that's not the right message to send, I think. So thank you very much for contributing that. All right, so we are out of time, but I'm going to ask one more question. I'm going to take the liberty. I'm afraid we didn't get to a lot of cases, but we have talked specifically about certain types of patients. But Yahya, you've done lots of trials over the last 20 years and so on, and you've got a view of what trials are coming down the pipeline in the next 10. So maybe my final question, kind of paralleling where we started, what are we going to be doing differently in 10 years' time?
I think in 10 years time, I hope that we would have a more personalized, individualized approach to sedation, where the patient, you know, whether a post-operative or older or younger or medical or septic or non-septic, with a bit of, you know, background, each patient will have a different need of a different sedative. So I think I hope that we will have enough trials to move us towards more of an individualized, personalized approach to sedation and analgesia in those patients. Yeah.
Excellent. Thanks very much indeed.
Yeah.
Thanks to you all.
Thank you, everybody. Enjoy the conference.